Bom dia. Bom dia a todos e todas. Eu gostaria de dar para todos vocês as boas-vindas para esta nova USP Lecture, Transforming the Youth Mental Health Workforce, transformando a força de trabalho da saúde mental nos Estados Unidos. Quem vai proferir vai ser o professor Chris Brown, da Universidade de Texas at Austin. Welcome, professor. Welcome to USP. My name is Susana Torresi. I am the Vice Provost of Research of the University of São Paulo. And it is my pleasure to introduce you Professor Carlos Vinicius, that is going to welcome Professor Chris Brown. Okay.
Bom dia a todos e todas. Fico feliz em estar aqui presente com vocês, né? Primeiramente, falar em algumas palavras em português, né, enquanto professor colaborador aqui do Instituto de Psicologia, né, e também para aqui os presentes, mas também para os que estão em transmissão, né, porque eu acho que o grande volume de pessoas que posteriormente também acessarão a esse ilustre momento de hoje, né? Good morning, everyone. My name is Carlos Vinicius. I'm very happy to be here in this special data, in this special edition of USP Lecture. That is special to me because I'm professor and researcher at the Institute of Psychology and also a founder and a startup in this area that we will discuss today, né, in the called Dualtech and created within USP's innovation ecosystem, right? So working specifically integrating psychology, AI, and big data to assess student mental health. And I'd like to thank the Dean's Office of Research and Innovation, name of the Professor Susana, to support this important event, and Professor Alessandro to organize this moment to stay here together, right? Today's talk is part of our international collaboration efforts to improve mental health and well-being in universities. We are honored to receive a guest who is a true global reference in the field, Professor Chris Brownson, Association Vice President for Health and Well-being at the University of Texas, UT, at Austin, and clinical professor in the Department of Educational Psychology, right? Dr. Brownson has over 2 decades of experience leading health and mental health service for students. He has coordinated projects totaling almost $30 million across 14 institutes of the University of Texas system. His work focuses on mental health policy, suicide prevention, and how well-being affects academic life and success, right? He has served on national committees in U.S., including National Academies of Science and the Higher Education Mental Health Alliance, right? And has leading important research on suicide prevention and student well-being. The title of today conference is Mental Health and quality of life in university. Dr. Chris Brownson will present him trajectory and strategies that have been used at UT Austin and across the US to promote mental health, prevent crisis, support recovery, and improve the academic experience. So his work is relevant for us in Brazil as we look for innovative ways to care for our students and improve academic environments, right? So now, after these words, let's begin. Please join Professor Chris Brownson, and thank you to be here with us.
Obrigado, 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 obrigado. It's so nice to be, I feel like I'm with all my friends because I've gotten to know you over the days that I've been here. So it feels different to present to in an auditorium that's as formal as this to people that I feel like I know. I feel like I should come and sit in the seats with you and we can just have a circle and talk. But I'll do the formal thing up here. So first, I'd like to, so some pictures from the week, my new friends. And I wanted to just take an opportunity to thank you, Provost, for the introduction and for inviting me to be here. What's the, I always say it wrong, FSEPSI. Yeah, for funding the, this initiative. And we've had a very full week and a very nice week together so far, and I've really appreciated all the exchanges we've had. And we were honored to bring Carlos and Dannerly and Provost Casilla to the University of Texas, in 2004, right? In January, a very cold January 2004, and received them, and they gave presentations to our staff and our students there, which were very, very well received. So we really appreciated that collaboration. And one thing I want to just share is that in my time here so far, one of the things that I'm most struck by is how the challenges we face in the United States related to student mental health and well-being are very similar to the things that you're dealing with in Brazil. No surprise, they're people at the same age facing many of the same challenges and some different challenges. But I think what also has struck me so far is the ways in which you all are using such innovative ways of addressing the challenges that students have. Some of them similar to things that we're doing, and some of them very different and very important. And so I've learned a lot over the last 3 days, and I'm excited to continue to learn as we further our collaborations together. Okay, I did want to say, I have been practicing my Portuguese. I'm on level 9 of Duolingo. I think that is like maybe a 3-year-old child. So I can ask for coffee or tea, both. And I can introduce myself, and I can thank you a lot. That's it. So when we talk together today, you can ask me questions in Portuguese, as long as they are about, whether I like my daughter, if she's nice, things like that, and I'll be able to answer those. Other than that, we'll need to do some translating. And Carlos, today, as we talk, I've done some of my slides in Portuguese as well, but maybe I know when we were talking in Ecos, there was some translation, and so if we need to do that today, can we do that also? Yeah, okay, perfect. Tutto bene. Okay. Well, in thinking about my career in the 25 years that I've been working as a psychologist at the university, one of the biggest challenges that I've had is understanding how to meet an increasing demand for services. This is a study that was done of adults in the United States, and it was looking at adults who seek help for psychological services for mental health reasons from 2002 to 2020, so approximately over a 20-year period of time. And during those 20 years, the demand, the number of people seeking services increased by 52%, okay, from 27 million in the US to 41 million in the US. During that same time, though, the US population only increased by 14%. The number of psychologists only increased by 7%. The number of psychiatrists by 11%. And I think that is the major problem that we've been dealing with, is that the demand for services is going much more quickly than the number of psychologists and psychiatrists that we have to help them. Does that make sense? Yeah? Okay. Is that the same here? Yeah? Yeah? What do you think maybe are some of the reasons why we're seeing such high demand increasing? Do you have a theory about that or a thought about that? Just call out. Does the question make sense? Yeah, yeah. It's a difficult question, though. And you can call out in Portuguese, and Carlos will. So partially maybe the pandemic. We have seen since the pandemic a steeper increase, but also it's been going on since 2002 as well, right? So it's been increasing before that too. Yeah. Some of the reasons I think we see are less stigma. Yeah, less stigma. So when I was in college, it was embarrassing to go and see a counselor. And now Mufilha, which is she's here in the audience, my daughter. She and her friends. I always hear people her age talking about going and talking to their counselor or to their psychologist, and it's not the shame that I think when I was in school. So that's one thing. Other thoughts? Please. Yes. Yeah. Yes. And in our country, we've been giving the message to people for a long time that you should seek counseling. Seeking counseling is a good thing. It's helpful for you. It's good for you. It can help you learn about yourself and be more healthy. And all of those are very positive messages and have I think increased those numbers. But there's something I want to say after Cassia makes a comment.
Eu queria citar dois elementos que eu suponho que façam parte do aumento dessa curva. Colega Pedro citou na segunda-feira, que tem a ver com a crise de 2008, E acho que também tanto um processo de medicalização da vida e um aumento também da atuação da indústria farmacêutica em fornecer medicamentos para isso.
She pointed to aspects. One, socioeconomic or political, that we touch on the Sunday,
Yeah.
in seminar on the Sunday, the economic crisis that we observe in the first decade of the 2000 year, the years 2008, 2010, for example. And the other is the medicalization of the life, the pharmaco industry.
Yes, yes. Great points, Cassia. Yes, the advertisements for the medications that we see on television and encouraging people to seek that kind of help, and yes, and financial issues as well. So all these reasons contribute to these increases, and we have these messages that seeking counseling is good. The thing in the United States that's become problematic is that so many people have taken that message and started seeing a counselor, but our workforce has not kept up with the demand. We do not have enough counselors, psychologists in the United States to keep up, and that is the problem that I want to talk about with you today. I think that we've talked some, although maybe not with the folks with the people in this room, but in the United States we don't have the national health care. Okay, so health care is provided through private insurance, some public insurance if you're very low income or if you're elderly. But mostly through private insurance, and that private insurance is received usually through your job. You can either get it for free if you have a full-time job, or more common, you have to pay some when you have a full-time job. Because of that, on campus, this is the wrong slide. Don't look at that. Look at me. And so because of that, on our college campuses, we provide health care to students. So we have a medical clinic where we have 16 medical doctors who are caring for students for gynecology. Thank you so much. Gynecology, family medicine, urgent care, all those things. And then in the counseling, we have about 65 what you would call psychologists that are there to treat students for their mental health concerns. I think that's pretty different from the number that you might have on a campus our size in Brazil, right? Because you have other options for your students to receive their health care. So it's that context that is important to understand about how we provide services, and then the challenges that once our students leave campus and then they need to seek care. We talked about this a little bit yesterday, how challenging that can be for them to find care if they don't have insurance. Also, even if they do have insurance, which I'll talk about a little bit. So during my career, I've always struggled with how to take care of a growing number of students. This is the curve. I don't want to go into these numbers of increases over since 2009. I don't know why the numbers got black like that. That was, I think, in the airplane, something happened. And so this has been my major challenge of my career. So one of the things that I've done is tried to create innovative ways of providing services to students by having counselors that are embedded in the medical clinic that work with the doctors. We have a program called Counselors in Academic Residence, where we put psychologists in your language in faculties, which we call colleges or schools, and so we have the counselors embedded into those different locations to try to help with access. This is just a map of my my university, and the stars are where all of our counselors are. So they're all around the campus and all the different places that the students are. And the students are happy with the services that we provide. They say that the counselors do a good job and that they feel safe talking about the problems that they have. So it's not a matter of them not getting good service. It's just a matter of there not being enough of them. And then in my career, I have also tried to help with this difference between demand and supply. So I'm going to keep doing that, right? The demand, all the people wanting to seek services is going up and up and up, and the supply is of psychologists is not going up nearly fast enough. That's the major problem I'm talking about. So the other thing that we've tried to do a lot of is prevention and education, which we talked about a lot yesterday with the ECHOS team, which does such a wonderful job on campus. We learned about some of the peer programs and the book clubs and the communication campaigns that they're doing. And we do similar things on our campus too. One thing that is a little unique that we do also is we work with the faculty and try to also help the faculty not be mean to the students. Not, how do you say that, and not make the students unwell. And so we teach them ways to be better, to be kinder, to be more flexible to students, because a lot of times the faculty may be a source of stress for the students, right? So that's something we do. And all these efforts are great, but they don't fix this problem, right? Increasing demand and not enough people. So there was a study that was done in 2022 in the United States, and it was looking at, and I may want some help, Carlos, because this is maybe one of the most important slides, okay? And so what this slide is it's looking at the shortage of psychologists and psychologists in the United States. So they did a study to see how many psychologists and psychiatrists that they would need to treat substance use disorders and serious mental illness, which would be things like bipolar disorder, major depression, not mild depression, not anxiety, not grief, not anything like that, just substance use disorder and serious mental illness. And when they looked at how many clinicians short we were, the answer was 1.8 million. We need 1.8 million more psychologists and psychiatrists in order to only treat the number of substance use disorders and serious mental illness that we have. Can you help?
Corrijam-me se eu me entendi inadequadamente, mas ele está mostrando aqui, de todo modo, a força de trabalho e associado ao profissional de saúde mental, pensando os psiquiatras e psicólogos, terapeutas, conselheiros, e ele apresenta uma demanda do que é preciso, as pessoas que buscam esse tipo de profissional para determinadas demandas associadas a doenças ou transtornos mentais severos e uso de substâncias, e que é a demanda do profissional, o profissional, e a demanda populacional, a demanda da população que precisa desse tipo de serviço, Então há uma demanda crescente dessas pessoas que precisam desse serviço e um número fixo, específico de profissionais, Então há uma discrepância aí entre a demanda que é solicitada e o recurso de profissionais, que são fixos.
Obrigado. Yeah? So a bit of now we'll turn to economics. Okay, we'll talk about economics, because in the United States, the healthcare is not for free. The healthcare is to pay for. So when the demand is very high and the supply is very low, what happens with the prices? The prices go up. So if the prices go up because the demand is high and the supply is low, and since the supply is low, not everybody can have it, right? Because there's not enough. So who gets it? Who gets the rich people, right? People who can afford to pay then have access to the counselors. It's not based on what you need. It's not based on the severity of your concern. It's not based on the impact that it's having in your life. It's based on your ability to afford to pay for it. And that's right now how our system is working for mental health care. And I'm going to talk a little bit more detail about that. But before, you all, I learned this week, do something very different around your training for who can become a psychologist. In the United States, there's a lot of barriers to becoming a mental health practitioner. Let me show you. In our country, people who are allowed to provide mental health care, you have to either have your PhD, and then that's what we call a psychologist. In the United States, you have to have a PhD, and then you're called a psychologist. And then there are people who have a master's degree, and there's two kinds of master's degrees. There's a licensed professional counselor, LPC, and then there's a social workers, LCSW, SW for social work. But even for social work, that's you go to 4 years of undergraduate, you go to 2 years of graduate school, and then you have 2 years of working for almost no money while being supervised. And then after 8 years, you can be licensed in order to practice. Here it's 5, right? Yeah, more or less. For getting your doctoral, then add 2 more, so it's 10. So it's very difficult to become a, oh, wrong way. It's very, sorry, if you have what do you call it, when the strobe lights and you can have a seizure. If you have a seizure disorder, I may not be helping you. Okay. So it's very difficult, and it's very expensive. Our students who go to graduate school, because they have to pay, they leave graduate school with a lot of debt, maybe on average $50,000 for a master's degree, maybe $70,000, $80,000 US dollars for a doctoral degree. And just to say in a casual way, it's not like after these people graduate, they're not getting rich, right? So they're not making a lot of money afterwards. So this debt, you know, the $50,000, the $80,000 is really a challenge. And that's a barrier to becoming a provider in our country. I think I'm gonna go on instead of discussing, because I have more things I want to say. So with such a significant imbalance between the available mental health workforce and the demand, there are some very problematic issues that arise in our workforce, okay? So number one, there is no system that helps decide who does and does not get care. It's all at the caprichos do mercado, right? Yeah. And maybe for selling the Apple Watch, okay. Healthcare, I don't know. Yeah, that's that doesn't seem the way to me to give out a precious resource. Number two, private practitioners in the United States. Oh, private practitioners, just the psychologist. You know, psychologists in the United States. They are not wanting to be a part of insurance, because insurance is in the United States we would say it's a pain. You know, it's not a good system. So they are leaving insurance panels, and one of the major reasons is that, you know, I was saying you have to pay to get the counseling, right? It's expensive. It's maybe like, I don't know, $150 to maybe $225 for one counseling visit. Yeah. So that's a lot of money, but there are plenty of people in the United States that can afford to just take that out of their pocket and pay, and that's not a problem. So here, that would be what, 150 times 5, so that's 700 reales to 1,000 reales, something like that. You have a question? You look very surprised. Yes, the cost.
Could you say again?
Yes,
the value?
yes. So for one time to go see the psychologist. One time. One
session.
One session. It would cost you maybe somewhere between 150 to 225 US dollars. Yeah? Okay.
Thank you.
You're welcome. And the problem with that is that in the United States, most people, I don't know, 85% of the people cannot afford to pay $150 or $225 out of their pocket. But the 15% that can do it take up a lot of the counseling visits that we have because we have not enough counselors, right? So the ones who can afford to pay out of pocket use up a lot of the visits that we have for the psychologists that are available. And so psychologists are able to leave and not be on insurance and still make a good living, have plenty of clients that come and see them, and so they're not sometimes on the insurance. If you're on insurance and you charge $150, if the person uses insurance, I don't get 150, I get 80, maybe 90. So another reason people don't want to be on insurance is they don't make as much money. Okay, so that's another big reason why they leave the insurance panels. This is a study of people who have insurance in the United States, and they were talking about, in the top left, up at the top, the reasons why it was hard to find a mental health provider. And about half of people said that the mental health, the psychologist was not accepting new patients. 56% of psychiatrists, it was because they didn't accept their insurance, 11% for counselors, too far from their home, et cetera, et cetera. And this is a problem that's unique to mental health, because when you look here, this points, I think? No, I don't know. Does this point? Do I have a cursor? Oh, yeah. So for here, these are up here, the psychologists, okay? So 72% of the psychologists are like on an insurance panel, okay? While 28% are not. But when you compare that to a family doctor, almost all of them are on insurance. So it's much more equitable because they take insurance. This is a specialist, yeah, but the same. And then for primary care, which is family medicine, they're mostly on insurance. So this is unique to mental health. Okay, we talked about number 1, we talked about number 2. For number 3, unlike medicine, and this is really detailed, all mental health professionals in the United States, they are able to do all the same things. So if you're a psychologist or you're a social worker, you're allowed to treat all the individuals that may need mental health care. And that's very different from medicine, right? In medicine, you have a cardiologist that treats the heart, and you have the nephrologist that treats the kidney, and you have the pulmonologist that treats the lungs and the breathing. You have primary care So you separate it out based on your areas of expertise. And people get paid more for their expertise, right? A cardiologist gets paid more working on your heart than the family medicine doctor gets for your sneeze, your cough. And it should be that way, I think, because it's more difficult, it's more risky, it's more specialized. And the other thing it does is it makes sure that we have enough people in our workforce who know how to treat the heart, because people want to make more money, so they're incentivized to learn those advanced skills so that they can then help people who have the heart problems. If you don't make more, then wouldn't everyone just do the thing that maybe is not as complicated and is an easier lifestyle, and they're less likely to be sued by a lawyer if something goes wrong? And so then maybe people wouldn't be incentivized to do the more difficult things. In the United States, for mental health care, there is not an incentive to see clients who have more severe symptoms, because you get paid the same. If my student is suicidal, has bipolar disorder, or did I say student? My client, my patient, not my student. And for me, they're students because I serve students, but they're the patient, right? I make the same amount of money if I see the patient because they're sad that their pet died, their dog died. And that's sad. I mean, I'm not saying that's not an important thing and that's not a real issue, but they're very different skills, right? To treat somebody who's suicidal and to treat an issue of grief. But they get paid the same. So if two people call me and one says, I'm suicidal, do you have an opening in your practice? And the other says, I'm sad because, my friends, I'm having trouble making friends. And you have one, you can only see one, and you're going to get paid the same amount. A lot of people choose dealing with the friend and not the suicide. So then the most severe people are not getting the help they need in our system. Does that make sense? I mean, it does not make sense, but do you understand? Yeah, okay. I just said all these things, so I'm gonna go. Oh, this is, should I say this? How are we doing? Alessandro, when are we done? At 11? Take our time. Oh, well, I know, you always say that. Well, let me tell you this. So I'm doing a study in Austin, Texas, and this study is looking at the decision. Actually, I'm going to stop because there's conversations. Ask me questions. Maybe some things don't make sense. Any questions? Please.
Me again, sorry.
We are talking about, when you said that the price is the same for the issues being more serious, are you talking about the psychiatrists are in insurance or of the insurance? Because they cannot cobrar price, they cannot charge the value they want. How is this?
Yeah, we are only allowed to charge one price, and it has to always be the same. Yeah, so I can't charge a different price for one person than I do for somebody else if I take insurance, because then that would be seen as insurance fraud. Yeah, and then they do that, and then it's no good. And so it's the same price no matter what. Yeah, does that make sense?
Yeah, in the insurance.
Yes.
And out?
Well, if you don't take insurance, you have a little bit more flexibility, but nobody does that. It's still the one price. The one exception is that if there is somebody who who maybe is more poor, they may say, instead of the $125, I'm going to only charge you $50.
Social price.
Yes, yes. And maybe they'll see 2 or 3 people like that in their practice, because then it's helping society, and it's something they do to be helpful. But other than that, it's generally the same price. Yeah.
Thank you.
Yep. So I did so because of that, and this is another unusual thing. So imagine if you were to call your medical doctor and you had to kind of convince your medical doctor to see you, okay? So you call and you say, hello, yes, I have a rash on my arm. It's oozing and it's really, really raw and red and a lot of pus, and I need to see you. And they say, it's red and pussy. I don't think I have an opening today to see you. I don't want to. Yeah, I'm full. Maybe let me refer you to my colleague. Okay, that does not happen, right? Yeah, you need to see your medical doctor. You go online, you call, you say I want to make an appointment. You go in. But because the demand and the supply, the psychologists in the United States, they decide whether to see you or not. Okay? So you talk on the phone, and they talk to you, and then you decide yes or no. Are we going to start working together? So I did a study. I'm doing a study right now of psychologists in Austin about their decision-making about who they decide to see and who they decide not to see. And I want to share 2 quotes with you, but I'll let you read them. Because you'll probably prefer to read them in Portuguese. Or maybe you've already read them as I've been babbling on. Yeah, Will's saying that's true. Yeah. But this person, I think the title of my paper, do you know vibes? Does vibes? Yeah. Yeah, so there's a lot of talk about vibes. Do we vibe? Do we have the same vibe? Who cares if you have the same vibe? The person needs help and treatment, right? It doesn't matter if you vibe. But when you get to choose, then you pay attention to things like that. And then the second one is a big theme that we've been seeing in our research, which is looking to see the level of severity and deciding not to see people who have more severe symptoms. Like I was saying before, I told you what some of those reasons are. Now, I sound very critical of the psychologist in the United States by pointing these things out. But I have to say, this is me, although I don't have a private practice, but these are my friends and my colleagues and my classmates. These are good people. These are people who got into the profession to help, but they're in a system that doesn't work for them and doesn't allow them to make the choices they need to make. And, well, this is kind of funny. It's a joke from Twitter. So that's kind of like what it's like right now a little bit. But back to what I was saying. I mean, it's this person here, who was saying that. That was an individual who, if I remember correctly, was a single mom, okay? So if they have a patient that's suicidal, and then they need to figure out how to arrange for hospitalization, well, what do I do with my child? We don't have a lot in the United States of a safety net to help in those situations, so then that's up to the provider to do, and that's really hard. So they choose the less difficult patient because there's not a lot of help for them to see the harder patients. So there's a lot of reasons this happens. It's not because they're just greedy or uncaring, right? I mean, they're a part of a system, and this system is really kind of making them in many ways make some of these decisions. I think I'm going to skip this, although I hate to do that because these are interesting. Because I want to tell you about what I'm planning to do that's helpful, and you all are like a step ahead of us. So okay, those are all the problems. I've talked about the problems. Let's talk about some possible solutions now, okay? So one of the things that I'm wanting to do is this is our current, workforce supply, right? I talked about this. We have the psychologists, we have the social workers and the professional counselors. And what I am wanting to do, and we're starting at the University of Texas, is to create a level of what I would call bachelor's level counselors, okay? People who are trained to do counseling at that level. Right now, they cannot there's no such thing. There's no way to get reimbursed by insurance. There's no way to get paid. You can't be licensed as a bachelor's level person in the United States to provide counseling. So there's going to be two routes to the certification. One route is for current undergraduate students who can take courses and then do training. And then also for people who've already graduated from college but might want to re-specialize and come back into the university and become a counselor. So those are the two ways to get the certification. And I'm calling them CMHCs, Certified Mental Health Counselors. So one thing is that they need to be chosen carefully. I don't believe any person can do it. You need to interview, make sure it's the right person and a good fit, that they're well trained, so they've taken the right courses and they've had supervised experience, and then after they graduate, that they continue to be supervised. So unlike in my language, psychologists and the social workers and the licensed professional counselors, they can practice without being supervised by another person. These bachelors, the certified mental health counselors, they'll be supervised by one of those other people just to make sure. And when a client is more than they're trained to handle, then they can refer that patient to their supervisor. And these are some of the things they can do. They can teach mindfulness. Where's my mindfulness person? Yes. So they can teach mindfulness. They can do motivational interviewing, right? Motivational interviewing. Psychoeducation. They can teach skills. They can do mild anxiety and depression, adjustment concerns, right? The things that are the lower level symptoms, which is a lot of people going to seek mental health care. I'm not going to talk about that. So the plan that we have in place is a pilot project, and this is going to be within the University of Texas system. So there's 14 different schools in the UT system, like UT Austin, which is my school, but then there's UT Dallas and UT Arlington and UT Houston, and et cetera, et cetera, et cetera. All of us, we have health insurance through Blue Cross Blue Shield. You don't know Blue Cross Blue Shield? Yeah? Do we have Blue Cross Blue Shield here? Oh, really? Oh, interesting. Sounds like there's a story there. Yeah. So Blue Cross Blue Shield, and that is who provides health insurance for all the employees in the UT system. And so my bachelor's level counselors will be paid by Blue Cross Blue Shield through insurance to provide that care to the employees that work for the university system and their families. So that's like 300,000 people, because it's a really big system, 250,000 students. And so, there's about 300,000 employees. And in this pilot, it has to be scalable because it has to fit in the United States healthcare system. So it cannot be dependent on any government funding, on any institutional funding, on any grants. It has to be paid for by the healthcare system, because I want it to be able to exist and be replicated over and over and become a part of how we do healthcare in the United States. So there's 3 phases. I won't bore you with that. But here's what I think success will hopefully look like. So decreased wait times, because there's more supply. because we have a lot more people able to be in the workforce, increased access. I think providers will be more satisfied and patients will be more satisfied, a larger workforce, and better financial sustainability. So I think with that, I'm gonna stop. See if there's any questions or thoughts to share, and I thank you for your attention.
Thank you, Professor. Thank you so much. You show us on a broad view about the mental health policy in the US and how it enter in the university looking as a manager, observing the demands that come to you and how it demands you need to manage to respond in terms of structural perspective to give some academic quality of life, and in terms of the structural what I need as source, human source or financial source, so in front of this demands that is growing in US and obviously in UT too, right? So I want to open to questions or discussion, right?
Hi, Chris.
Hi.
How are you? Thank you for your
Tudo bem.
presentation. I was wondering if you could talk a little bit more about the. You were a bit before on another slide that showed about like how you think that your proposal can't be financed by government because it wouldn't be sustainable. I was wondering if you could talk a little bit more about it, because as we have the Brazilian reference very alive here.
Oh,
Which
yes.
is the SUS, the health system that we have here for 35 years, which has problems, but it's also universal and stuff like, So I was wondering, what's your thoughts about it? Like, if it's a diagnosis that you do, like more connected to real politics, like is it viable or not?
Yeah.
In the nowadays scenario there, or if it's something structural that you think it's like that should be avoided despite which government like is there.
Yes. I'm so glad you're asking me this question, because I'm now looking at this slide through your eyes, and I can see where I might have misled you in terms of what my intention was, especially with the big red X. Okay, here's what I mean by that. So my view, my opinion, is that government funding for healthcare should be the model. Okay, that there should be a system in place that is funded centrally that provides healthcare for everybody, so that healthcare can be accessible to everybody. That's my personal belief, Chris Brownson belief. That is far from political reality in the United States right now. And so what my interest is in my career right now and in building this level in the workforce to help with the supply and demand, well, really just the supply, is I'm trying to deal with the practical realities in the United States. And I know that if I create something that is dependent upon government funding, it won't work, because that government funding probably will not exist. If I depend on my institution for that support, I don't know, maybe for a while. But, we have a mechanism in our institution for students to come and receive an education, get a certification, and graduate, right? In our system, they come, they pay tuition, they take their courses, they graduate. So I don't need money for that, right? That's just how it works. Grants, you know, and foundations, when you're dependent upon that, it's only good enough until you get the next grant. That's not a way to build a system permanently into the healthcare system. So for me, I'm interested in building something that can be self-sustaining without any of those things. And like it or not, the system that we have for that is through private insurance. And that's why Blue Cross Blue Shield has been invited by me to be a part of this project. And I didn't spend much time talking about this, but it's pretty exciting that they said yes and that they're open to this. Because it's challenging the way they're doing business. They're going to have to pay for a whole new level of provider. And that's going to disrupt the way their business works. And they've been willing to sit with me and to see if they can figure that out for the good of the patients they serve. So I commend them for that in terms of their willingness to have that conversation. But if I try to do it without them, it can't work. It has to work within the system of private insurance, or else it can't work in the United States right now. And that's what I meant. So it wasn't my value, government funding. It was the reality of how it works. Yeah, great question. Thank you.
Hi, thank you very much for the talk. It was very interesting. So the slide with the number of practitioners that needed to was related to drug abuse, right? But my question was more broad. If the so this is only for drug abuse, right?
For substance use disorder, which would be drug abuse, or serious mental illness, which would be like bipolar disorder, schizophrenia, major depression with serious suicidal ideation. So the most serious psychological issues.
Yeah, because that was my question. Because I was wondering if there is an increase in pathologization of regular human interaction that lead people to needing unnecessarily to see clinicians, and people who are actually sick, like those people that you mentioned, that actually need to see professionals. If the core of the root of the problem of its lack of workforce or lack of prioritization of people that actually need and a culture, especially the young if the younger generations are seeking more mental care and they actually don't need it, and they deprive this from the people that actually need.
Yes, that is one of the core issues, is that, and I would say it a little bit differently, but I think what you said is true. You said that maybe since with younger people that it's more acceptable and maybe they don't need it. And I think need it is a very interesting discussion. And it's back to what I was saying before about how we've been giving the message that everybody can benefit from counseling. It's true. Everyone can benefit from counseling. So I don't know what need it means, because it is helpful. And if we had all the psychologists that we needed, a system where everybody could go and seek care at any time for any issue, including self-improvement, self-actualization, understanding yourself better, that's what I wish we had, right? Because those are all great ways of using our expertise as psychologists. Unfortunately, in the United States, there's such a shortage that then you have to start to figure out a way to ration that, because there's not enough. And then the need it becomes a real issue, because if you're going to create an ethical system, it seems to me that that system would be giving it to people who need it the most, and that they would get the precious resource. If there was a shortage of glasses, and only some people could have glasses, I would imagine we'd probably do it to where the people who have the hardest time seeing get the glasses. And then, I can't see any of you right now, by the way. You're just a big blur. Um, but if you wanted to wear glasses because they just look good, you know, it's like, I look good in glasses. No, you don't get glasses. There's other people who can't see. They're the ones that need the glasses, right? So I think that's kind of what we're dealing with the mental health care part.
Thank you. And just a quick question. So you mean all the self-actualization I agree with? Do psychologists and psychiatrists should be the main providers of self-actualization, or should be people who don't need that much time to prepare and actually be more broad, you know, like because I think that self-actualization is something that happens for generations, and we had shamans and we had like the elderly, and we don't have that anymore. So
Yes. Yeah, I think absolutely. And one of the slides I skipped over that I just kind of ran out of time to talk about is that part of the inspiration for this project really came from came from a few different places, but one of them that relates to what you're saying is when we started our peer program at the university. We call it Longhorn Share. You know, the Longhorns, that's our mascot. And so once I started seeing how effective that program was, where peers are just having groups with other peers and talking, that was one of the things I thought too, right? It's like, well, gosh, if this is effective, imagine how effective it would be with trained, you know, bachelor's level persons. But yes, your faith communities, your families, your circle of friends, your, you know, trained peers, there's so many ways to get that support. And I think we've seen things in our society, and I would imagine it's similar here in some ways, where those structures are breaking down, and then people are having to rely more and more on professionals to get things that they used to get informally, right? Yeah.
Hello, Chris.
Hello.
Dr. Chris. Well, I got lots of insights to take home, so thank you very much. And we would like to know if there is any tool to evaluate the students' satisfaction about the service, and if there is, how do you do that? And how do you work with this feedback to feed the improvement of the service? And you just told about the healthy horns.
Yes.
And I got a little bit more about this, what you just told, and how this pathing works, and the training of this. There is a training of these students,
Yes.
and how does it work?
Yes.
This peer training.
So the first question is, how do we evaluate the services that we provide right now, the current services? Yes. And then what do we do with that information? So let me start there. There's a number of ways that we evaluate the services that we provide. When a student, a patient, I keep saying a student, you understand that, right? Because they're the students that we see. When our patient comes in to see us, after the counseling session, we send them a survey, and they answer some questions about their psychologist and about how useful it was and if it helped them. We have ways for our patients to give informal feedback that is not associated with their name. So they maybe want to say something, but they don't want anyone to know it's from them. And they can do that online through an online submission form. But one thing that we do that's kind of unique is we do surveys every few years of students who have not come to see us for counseling. And we ask them why they haven't decided to go to counseling with us. They didn't need it, okay? They didn't know we existed and that it was anything that we offered on campus. We talked about this yesterday with the ECHOS team, that you know, we, despite our best attempts at communicating, that sometimes they don't know that that we're there for them. Maybe they've heard negative things about us. And we want to then know that so we can correct those misperceptions if that's not true, or if it is true, that we fix the problem. And so we ask those questions as well. So that's how we evaluate, and that's what we do with the information. For the second question, I think you were asking, how are we going to train? Is it the peers? How do we train the peers? Or are you asking, how will we train the new bachelor level providers that I'm talking about? The peers. So the peers do, it's a part of a class. So they take a class and there's an instructor, and the instructor teaches them things like motivational interviewing, mental health first aid, how to like know if somebody's suicidal and what to do about it if they are, active listening, okay, and then how to create like programs. So they take a class and they learn those skills, and the class is for 3 semesters. So first class they just learn. The second class, then they create their group, and then they do the group, and then in the third semester they do the group again. So 2 semesters of doing the work and 1 semester of learning, and that's how they get trained. Once they're doing, they're also supervised, and they have supervision groups. They get together and talk to the other, I think you all called them guardians, right, in the peer program that was out in the rural area, right? Yeah, we just call them the peer supporters, so, yeah.
Hello.
Hello.
Thank you for your explanation.
De nada.
I'm so sorry for my English.
Your English is much better than my Portuguese.
I don't know.
Well, we'll see. We'll see. You say it, and then we'll decide. Yeah.
I will try. I will try to. Carlos, you can help me a little. Carlos.
Yes, you're perfect.
Yes,
you're doing great.
I will try. I can speak a little Spanish mixed. Well, the question that you make is very complex. The reasons of improve of mental health problems. I'm really worried with the young people, especially the students, and worried to understand which elements of universe can contribute to this improve. I think the great reason of this kind of problems, health problems, mental health problems, is from the social conditions. Particularly the conditions of life and work. I think there is a situation, the degradation of work, the degradation of cooperation in the work, competitive attitudes, model of evaluation of work, individual, contribui muito para o individualismo, né? De precarization, there is precarization, existe isso. Intensification of work and degradation of work, a process of intensification and degradation of work. And I think if I have reason in this reflection of the importance of work and social determination of problem health, the mental health, the people who work in the bad works are more vulnerable to the sick and less access for the service. like you show. The people who more need less access, bad conditions of life, I think the situation of the people who more need can improve negatively. And the people have situation little better, could be access condition, economic condition better, and condition, psychological condition, no too serious, can receive the service and be successful. Well, I don't know if you understand.
I do. I understand perfectly. Yes.
General idea
Yes.
that I think
Can I say-
reflect.
Can I say two things about that? Yeah,
And,
'cause
and what you think about the ingredient of universe that can be contribute to the student health
yeah,
problems of mental health.
yeah. I think that's a
Please.
great, very good question and good observations about the ways in which people's, that social factors come into play related to people's health and well-being. It's not just about adjustment or for students, their courses and things like that. It's generations of history related to, you know, who they are and how they identify and their access to resources, and that is a big issue that cannot be solved by a psychologist in one counseling session, right? There's social factors that have to be taken into consideration. Is that a little bit of what you were meaning? Yeah. And so I think universities can play a big role in that. There's a story that people tell related to prevention, and hopefully it translates good. But it's there's these group of people. Okay, it's like a story. Let's pretend. There's this group of people, and they're standing by the river, and they see all these people floating down the river, you know, screaming for help. Help me, help me, help me. Do you know this story? Yeah? You know this story? Oh, no. And so they say, help me, help me. And so the people on the side of the river start pulling, you know, the people out of the river to help them, right? That makes sense? And there's more coming, and there's more coming, and there's more coming, and they're helping. Well, then this one person leaves. He just leaves. And they're angry. They're like, where did you go? Why are you leaving? And they said, well, I'm going to go up the river, and I'm going to see if I can figure out why they're going into the river in the first place, right? They wanted to find out what it was that was causing all the people to be in the river. Well, that's the prevention work that we do. That's the social factors. That's the trying to create more equality and provide greater income for people. Those are things that matter tremendously in people's health and well-being. And so those absolutely ought to be things that we're focusing on as well. So that was one point. And then the second point is like, you know, gone. I can't remember it. Yeah, but I had two things, but I only remembered the one. Yeah. I got into my story. Have less. Yeah. Yes. Yeah, with equity. And that's what that I think in our system, it is, there will not be equity if there is a discrepancy between supply and demand. When those differences exist, the way our system works is that those who have access to the resources will be the ones who get the resource. And that's why I believe it's so important to create more supply into the system with more people wanting to do this kind of work. So I think that's one solution, one that I can control related to equity. There's a lot of other ways of creating better equity through law, through policy, through funding, but those aren't things I can do, right? I can advocate for it, but I can't do it myself. I feel like this is something that I can do, and that's why this is the project that I've chosen to work on. I do remember the other thing I was going to say related to your point, because you were talking about the degradation of work and how much how much time people are spending. I think if I understood working, and that also causes a lot of problems with mental health and well-being. Did I understand correctly? Yeah. And so there's an interesting study that was done in the United States of college students looking, and it followed college students from the early 1980s up until, I don't know, I think it was like maybe until 2020, okay? And it was looking at two things. It was looking at the amount of time each week they spent socializing with friends. Do you remember this? Okay. Yes. So I think about, well, not everyone was there, so maybe I'll say it real quick. So socializing with friends and how much time you spend studying. And then they followed those two things over time. In the 80s, in the 1980s, students on average spent, I think it was 32 or so hours per week socializing with friends on average. And then studying was like 16 hours per week. I went to school in the 80s. That's about right. Maybe 16 hours studying. Jesser, you probably study a lot more than that, right? Yeah, all right, well, that's where I'm going. So that now in 2020, it's the exact opposite. Students are spending time studying about 35 hours per week and socializing with friends 15 or 16 hours, because the work is so much more. It's so much more pressure, whether it's school or work. And so I think we see this very disturbing trend. And to your point earlier, Dannerly, after the pandemic, it really started to accelerate. A lot more studying, a lot less time socializing with friends. So I don't think it's getting better. And so I think the work issue and the demands of work and studying for students is a real problem too. Yeah. Okay. Well, I know more. I mean, I want to be not
Okay.
hold you hostage.
One final
Yes.
question. As we noted, we have here two provosts that are in a area of psychologists, right? And you, as vice president, psychologist too, right? So my question as psychologists, and thinking how the psychology can contribute through the governance, university governance and academic governance, in your point of view, in your point, how as psychologists you can contribute for the university governance, academic governance.
Yeah. Well, I have an opinion, but I'd be very interested to hear from Provost Ricardo, Provost Cassia, and Carlos. You're a great example of that, because in your role here, you were on the campus master plan committee, helping as a psychologist to make decisions about how the University of Sao Paulo should grow, what it should look like, what the spaces should be like, the green and the blue spaces, what the buildings should be like. That's a great example of how our expertise as psychologists or other health professionals, as you all are, and experts about students, can inform decisions that universities make about the structure of curriculum and our built environment and things like that. So one of the things for us is that people have to know that we have that expertise, and we have to advocate to be in those situations where we can help influence those policies, and then we have to be invited. And if we're not if we're not asked, it's hard to contribute. I'm sure, right? I mean, you couldn't have just shown up to the committee, even though they didn't invite you, and start telling them what to do, right? You got invited because of relationships that you have and because of the, the talents that you have. And one thing that I noticed, I don't know if it's the same here, but in the United States, this is good news. I feel like mental health is very valued on our college campuses. When you survey presidents of colleges and universities, they ask them all these questions every year, like, what are the things you're most worried about? And I would say over the last 10 years, in the top 3 concerns that presidents have, and presidents have a lot to worry about, right? Money and the faculty and blah, blah, blah. They say mental health is one of the top 3 things that presidents of universities worry the most about is the mental health of their students. That's good, because that means they're paying attention, they're aware of the problems, and then they know that we have expertise to contribute. So I think we have a lot that we can do to be helpful. Yeah. But Cassia and Ricardo, if you have anything you want to add?
Just as important using the microphone because we are in a transmission. Would you like to say something, Professor? Or Cassia, would you like to say something? First to you or Cassia? Cassia.
And thank you, Professor, for your presentation and ideas and democratic form of dialogue with us. I think the contribution combines political awareness and mastery of democratic management practices. A reflection that contributes to the student participation, the listen of community, student community. It's fundamental on management in context of governance. But we managements, we had knowledge about management, technicals, practices, funded by public policies, but with psychologists, the political listening is fundamental for decisions, for formulations, and how do you say principalmente? Principally, no? mainly for the university image, university, how do you say, aura, espírito?
Reputation.
Reputation with a radically democratically university. I don't think that would be different in other professionals, but I think that with us como psicólogos, the listening is fundamental. So no should suggest, no previous knowledge, but listening and the
exchange.
Dialogue.
Dialogue.
There's no impediment communication, no hierarchical communication, but horizontally communication with all actors, management, students, professors, workers, and social movements.
Thank you very much. Very interesting all you say for us. Her answer is perfect enough. But here in University of São Paulo, essa gestão this writer have decided that to be a university with a very high quality in research and other things, they need to do the importance for the belonging and inclusion of all the kinds of students. So we have here a new provost named Inclusion and Belonging to think and to transform the way how the university have the research, not just the results of the research, but to take care of the researchers, to have research more with importance to the society, to have more other questions that the diversity of the public of the university can contribute to new troubles and new views of the society. And I think this kind of view contributes to make this university better. Thank you.
Thank you. And I've been so, as I've heard and over the past few days about those different kinds of programs that are a result of the Provost of Inclusion and Belonging on, different campuses, Bahia, University of Sao Paulo. So impressive to hear those kinds of programs that you're doing that provide support to all students, and sometimes the ones that are most overlooked or that struggle the most, and making sure that you have the things in place to help everybody on campus is so commendable and important. So yeah, it's nice to hear of that work.
Okay. Thank you, Professor, to share your expertise and experience to us. And I think that you bring some reflect to help us, not specifically here, São Paulo, but Bahia, and then UT in this interchange to build these academics spaces as healthier, more supportive, more inclusive the space to all of us. So thank you very much, and thank you everyone to join us this morning, right? All these week activities that we have, and so have a great day, everyone. Thank you so much.
Hey, Dannerly?